Yeah, good afternoon again, all of you. In this session, we will be discussing the ultrasound examination of the liver. We'll be discussing the normal appearance of the liver on ultrasound examination, and the ultrasound examination techniques, and then in brief about some pathologies. The pathologies we'll be discussing in two sessions, which will be diffuse liver disease and the focal liver disease. Before going into the details of ultrasound examination appearance, let's summarize the gross appearance of the liver. As we know that liver is divided into two lobes, that is left lobe and the right lobe, by what is called as falciform ligament. This is actually the remnant of the ductus venosus. We can see the various ligaments of the liver, the left triangular and the right triangular ligament, which are actually the folds of the peritoneum, the parietal peritoneum, visceral peritoneum. And what is known as porta hepatis is around the undersurface of the liver. From surgical point of view, the liver anatomy is divided into 8 segments, what is known as Coignard's classification of the hepatic segments. This is basically based on the vascular and biliary anatomy of the liver. There are 8 segments. The segment 1 is just located anterior to the IVC. The segment 2, 3, 4 are located within the left lobe of the liver, while the segment 5, 6, 7, 8 are located within the right lobe of the liver. The common indication for the examination of liver is definitely for subcostal pain, or it can be due to for any examination. So liver examination is part of abdominal examination. We do commonly do it for any other reasons as well, for infections, for localization of metastatic malignancy. N number of indications are there. So the transducer used for examination of liver is definitely again the convex probe, as we need to reach the deeper depth. Of course, for superficial liver parenchyma and for pediatric population, the linear probe can be used. There are two approaches that the way we can examine the liver on ultrasound examination. For right lobe of the liver, it is better, it is scanned through the subcostal and intercostal spaces. Whether it is anteriorly or laterally, you can use the subcostal and intercostal spaces. While for the left lobe of the liver, it is imaged through the subxiphoid approach in the epigastric region. So just inferior to the xiphosternum, you put the probe in transverse and longitudinal fashion, and you can examine the left lobe of liver. So this is the probe position for examination of right lobe of liver. We can see the probe is placed within the intercostal space between two ribs, so that the rib shadowing is avoided. And is how the subcostal approach is. We direct the probe somewhat cranially and put the probe in along the subcostal line. And we can do two methods. We can ask the patient to take a deep breath and entire liver parenchyma will be scanned on its own. Or you can just direct the your probe itself. You can move the probe in a craniocaudal direction slightly, and you will be able to examine the entire right lobe of the liver. Similarly, for the left lobe, if you put the probe in the longitudinal fashion in the hyposternal area, we can see the left lobe of liver. Just inferior to the left lobe, we can see the gastroesophageal junction, and some part of the pancreas can be visualized. Now, if you put the probe in a transverse fashion and direct it somewhat cranially, we will be able to visualize the IBC, the hepatic vein confluence, and various segments of the liver. Of course, the porta hepatis is located along the undersurface of the liver in a gross anatomy, but you can see the porta hepatis either from the right lobe or from the left lobe. Better it is visualized from the right subcostal or intercostal approach. At the porta hepatis, we can see an tubular anechoic structure, which is the portal vein, larger one. The hepatic artery and the CBD will be seen somewhat cranial or adjacent to the portal vein. IVC is seen posterior to the portal vein. Once we put color Doppler, we can differentiate between the structure. So normal portal vein will have a hepatopital flow, that the flow will be towards the liver parenchyma. You have to compare it with the hepatic artery. So as the hepatic artery will always be flowing towards the liver parenchyma, if you put the color Doppler on portal vein and compare it with the hepatic artery, will be able to decide whether the flow within the portal vein is towards the liver parenchyma or not. A normal portal vein will always flow towards the liver parenchyma. But what will happen in case of portal hypertension? There will be resistance to the flow of the portal vein into the liver parenchyma, and that can be there can be dampening of the flow, and in severe cases there can be reversal, intermittent or permanent, persistent reversal of the flow can occur. Talking about the arterial anatomy, definitely the hepatic artery proper arises from the celiac trunk. It is a branch of celiac trunk. Once the hepatic artery reaches the porta hepatis, it branches into right and left hepatic arteries. There are some variations. The hepatic artery origin of the hepatic artery, right and left hepatic artery, there are variations. We will not be talking in detail about this such brief session, but we'll be talking it if we are going to go for a detailed session. So hepatic artery common divisions are like this. As we can see, the origin of the celiac trunk over here, there is celiac trunk, and there is splenic artery going to the left and the hepatic artery proper to the right. And the hepatic artery proper now will branch into right and left hepatic arteries. So this is one video in which we will be discussing various structures which will be seen during the ultrasound examination of the liver. Just play the video for me, Noreen. Noreen, can you please play the video for me? As we can see, this probe is somewhat in the right subcostal region. We are able to see the branching of the portal vein, main portal vein, as well as its right and left branching. So now if we direct the probe somewhat cranially, we can see the IVC, we can see the confluence of right, left and middle hepatic veins, which are draining into the IVC. Once we put color Doppler, we can see the flow pattern. The hepatic veins and the portal vein branching will help us to differentiate between various segments of the liver. So as we can see, right and left and middle hepatic veins over here. The middle hepatic vein will divide the liver into right and left lobe, while the left hepatic vein will help us to differentiate between the upper and lower segment of the left lobe of liver, and right hepatic vein will help us to differentiate between the anterior and posterior segments of the right lobe of the liver. Similarly, we can see the portal vein over here. The segments which are above the level of portal vein in the left lobe of the liver, they are segment 2 and 4A. In right lobe, above the level of portal vein, they are segment 7 and 8. While in the left lobe of liver, the segments which are below the level of portal vein are actually segment 3 and 4B. And in the right lobe, there will be 8 and 5. We can, with the help of portal vein branching and hepatic vein branching, we can localize the various segments of the liver. We can see the gallbladder as well over here. All the structures together at the porta, we can see the IVC posterior to the portal vein. And the segment which will be just anterior to the IVC will be segment 1 of the Poinard's classification. Let's talk in brief about the various pathologies of the liver. First of all, diffuse liver disease. The diffuse liver diseases will be involving almost entire liver parenchyma. There are various types. The common is liver cirrhosis. Definitely, recently many of us are coming across what is known as liver steatosis or hepatic fatty liver disease. What is called fatty liver disease? So diffuse infiltration of the hepatic is very common, but though in stage 1 and stage 2, it is reversible, and if it is reaching into fatty liver stage 3, it can progress into liver cirrhosis or what is known as NASH, non-alcoholic steatohepatitis. So diffuse liver disease other types are there. There can be various deposition, liver parenchyma deposition diseases like various liver storage diseases, etc. Then there is There can be congenital storage disorders as well, and which we rarely see. That's why. So liver cirrhosis is the most common disease. We can see the appearance of the liver and liver cirrhotic patient. There is somewhat heterogeneous appearance of the liver parenchyma. We can see multiple tiny echogenic fibrotic bands within the liver parenchyma, and there are nodules. There is irregularity or nodularity of the hepatic capsular outlines, which is seen better using a linear probe. Talking about the focal liver diseases, most common again is the simple hepatic cysts. Many a time we'll be coming across simple hepatic cysts, which are just simple pathologies. They are of not much significance unless they are associated with other cystic diseases, like one in this image which is showing multiple cysts within the liver, as well as multiple cysts within the renal parenchyma, which is diagnostic of autosomal dominant polycystic kidney disease or multicystic dysplastic kidney. These patients are associated with renal failure, then it can be hypertension, etc. So simple hepatic cysts will have an anechoic, appear as anechoic structure with thin imperceptible walls or maybe slightly echogenic walls, and will not be having any much septa, will not be having any solid component, no wall calcification, etc. Common cystic or the complex cystic disease of the liver is hydrated cyst. As we can see, it is a double layer cyst. We can see two layers of the cyst, which are exocyst and endocyte, and again within the cyst there are daughter cysts. Is a common typical appearance of the hydrated cyst, though there are varied appearance according to the stage. That times the hydrated cyst can be very simple. Only two layer of this layer of the cyst wall will help us to differentiate it between the simple hepatic cyst and a hydrated cyst. So hydrated cysts will always have these two layers of the wall. We can, according to the stage of hydrated disease, we will have loose membranes floating within, which was also called as water lily sign. And if it is in advanced or degenerative stage, we can see calcification and shrunken hydrated cysts. Common solid hepatic focal liver diseases, again, depending upon the ultrasound examination, it is a bit at times difficult, but if you are talking about common pathology like hemangioma, the hemangioma is very common hepatic solid masses, and on ultrasound examination they appear as brightly echogenic, homogeneously echogenic lesions. They will have distal acoustic enhancement, but at times they can have varied appearance. They can be somewhat hypoechoic, but most of the times they will have well-defined margins. And on ultrasound examination, it is easy to differentiate between a typical hepatic hemangioma and other pathologies. Usually malignancies of hepatic parenchyma, they usually present with somewhat varied appearance. They are not that much brightly echogenic. They are hypoechoic or heterogeneously hypoechoic, and at times that can be somewhat echogenic. So again, contrast enhanced ultrasound examination can help us to differentiate between various pathologies, that benign and malignant solid liver lesions. Though it is not commonly done because CT and MRI has a better resolution, or you can say spatial resolution. We can differentiate it better on CT and MRI, but ultrasound, contrast enhanced ultrasound is also equally good. As we can see, the liver hemangioma is appearing somewhat. It is a typical hemangioma, which can be seen as somewhat irregularly marginated, but when encapsulated, heterogeneously hypoechoic lesion. The bottom images. On contrast enhanced ultrasound examination, the lesion is showing intense enhancement along the margins during early phase, and as the examination is progressing, we can see peripherally filling in of the contrast, which is typical of a hemangioma on all contrast examinations. We can see CT on MR also, the similar appearance can be seen. Another lesion which is heterogeneously hypoechoic, that is suspicious of a malignant lesion, can see the hepatocellular carcinoma. And on contrast enhanced ultrasound examination, we can see brightly enhancing vessels within the lesion during arterial phase, just 10 seconds after administration of contrast. And during delayed phase at 3 minutes, we can see the contrast is washing out so easily. Even during the 1 minute phase, we can see the contrast enhancement is homogeneous. Another important benign lesion which is seen which is a hepatic adenoma. On a contrast enhanced ultrasound examination, we can see the lesion is heterogeneously hypoechoic on B mode, which is difficult to differentiate it between a malignant and benign lesion. Once we administer contrast, we can see the lesion is showing persistent enhancement. There is no washout of the contrast during the delayed phases as well. So this is in favor of being it is a benign lesion. So that is how a contrast enhanced ultrasound examination can also help us to differentiate between malignant and benign lesions. Okay. So that's all about, in brief, ultrasound examination appearance of normal liver parenchyma, and in brief about various liver pathologies. We can discuss all these pathologies in detail in our course. Thanks again.